So now this is scenario 53 years old businessman who presented with upper abdominal pain, jaundice, anorexia. This is his history, and he was diagnosed as a case of acute and chronic alcohol liver disease. Now we are going to study something about it. This gentleman has developed the evidence of long-standing liver disease, which is mostly secondary to alcohol consumption, supported by high MCV, low urea, poor synthetic functions, low albumin, and prolonged international normalized ratio. We can see here his urea is decreased, MCV increased, urea decreased, and INR is 1.6. He already had chronic liver disease. And now in this case, his recent step up in alcohol intake is likely to explain the cause of alcoholic hepatitis. It is less likely to be viral, as one would expect ALT levels to be much higher, but in this case AST levels are much higher. We can see it. AST levels are much higher. And ferritin is non-specific acute phase reactant, and this man's atrial fibrillation is secondary to alcohol cardiomyopathy. Patients are usually pyrexial. 50% have peripheral leukocytosis irrespective of infection. Is this patient having leukocytosis? Yes, white cell count is also raised. Okay, so hepatic decompensation with coagulopathy, encephalopathy, ascites is usual, and AST to ALT ratio is usually greater than 2, which we have already seen. Now there is discriminant function. It may be used to identify the patients at high risk of mortality and to select for the corticosteroid therapy. Discriminant factor 4.6 multiplied by prothrombin time minus control and bilirubin in mg per dl. More than 32 indicates a 1 month mortality of 50%. New Glasgow alcohol hepatitis score based on age, bilirubin, blood urea, prothrombin, and peripheral white cells count has recently been shown to be a better scoring system in predicting the mortality.